My name is Tammy Phan. I am a fourth-year medical student at California University of Science and Medicine in Colton, California. I'm presenting on behalf of my classmate Natalie Liu and doctors Malkoc, Nguyen, Cerceo, Nguyen, Lebedevskiy, and Dr. Toporoff. So our learning objective for this case is we've known that COVID-19 is known to cause severe medical issues in elderly patients. And the one thing that we wanted to emphasize is standard surgical therapy shouldn't be delayed in elderly populations as the risk of severe decompensation is high. So just a general introduction. Video-assisted thoracic surgery is a safe and reliable option to perform various diagnostic and curative procedures. In comparison to young, healthy individuals, though, elderly patients are often considered poor surgical candidates due to multiple chronic conditions or risk of general anesthesia, decreased cardiopulmonary reserve, and increased frailty. So in our case, we had this 95-year-old female who presented 2 weeks after she presented with the ground level fall, and she had increased oxygen requirements, multiple rib fractures, and a left-sided hemothorax. Initially, her management was planned with aggressive respiratory therapy, multiple pigtail chest tubes, and thrombolytics. So as you can see in figure A, or figure 1A, the patient initially presented with a left pleural effusion, and it showed initially significant improvement in figure 1B after she was given TPA and Doherty's. But due to extensive bleeding and visual field obstruction, we could see in figure 2C that the patient had a left hemothorax that increased its size and was extremely and almost entirely atelectic. So the patient was in the hospital. She wasn't improving much because she was diagnosed with COVID-19. So as a result, we decided that we needed to pursue aggressive surgical therapy. And in this case, she proceeded to the OR, and the procedure was converted to a video-assisted thoracotomy because the visual field was obstructed, and we could visualize multiple clots. So after the procedure, we took a postoperative X-ray, and we could see in figure from 2D to 2E, her left hemothorax or an infusion was largely resolved, and the left lung expanded. So postoperatively, the patient's clinical status was reviewed with serial imaging and oxygen saturation parameters, and she improved drastically. So in our working diagnosis, we can see that initially her incentive spirometry was 500 milliliters, and she was on 4 liters of oxygen nasal cannula in order to maintain her levels above 88%. But after her video-assisted thoracotomy, her chest X-ray showed improvement, and her oxygen dropped down to 1 to 2 liters for adequate saturation. So after hospitalization in the SICU, and she was downgraded and discharged, and she was able to report minimal pain. She was able to participate in physical therapy. She wasn't in isolation any longer. So her overall hospital course went well. So in this unique case with a patient with COVID positive, 95 years old, which is an extreme age for undergoing any major surgery, she significantly improved with minimal complications. And despite increased morbidity and mortality, the patient tolerated video-assisted thoracotomy and also demonstrated significant improvement. So in conclusion, we found that video-assisted thoracotomy and VATS is a safe, effective option, especially for surgical management and post-traumatic hemothorax in an elderly patient over 80. And VATS is superior to standard thoracotomy in terms of both morbidity and mortality. Therefore, age alone shouldn't be a contraindication to operative intervention. Thank you for your time and attention, and please let me know if you have any questions.
Very wonderful job. I loved that topic. So if thoracotomies are not to do with age as being a factor, are there any factors that you think would be a contraindication?
Okay. Aside from age, on the top of my head, I don't have an answer for you. But there were other, I guess you would say, things we considered aside from her age with like mobility, if she was able to, I guess, aerate and I would say be able to mobilize after surgery. We were considering that as well because we wouldn't have undergone that procedure if we didn't consider her being able to have a quality of life afterwards.
Okay, sounds great. Great job.
Thank you.